So good morning. I hope that everything is okay. It's a pleasure to us to be here today to talk about the prevention in urology. My name is Cristian Fiori. I'm a professor of urology in the University of Turin, and Professor Manfredi is one of the other professors in urology of our university. So I think that we can start. I give the chance to speak to Professor Manfredi that introduced the topic of prevention in urology, which is a so important topic today. And then we go through the most important topic inside the prevention in urology. Okay? So have a nice morning.
Thank you, Cristian. Thank you to all of you to be here. Okay. Just a little, for us, a little talk about prevention, because when we started to prepare this seminar, first of all, we needed just like a definition of prevention, because we talked about prevention just during the university, as for you. And then in the everyday practice, is not so frequent to talk about prevention. That is the first take-home message that we want to say to you, because for clinics and also for academics, prevention is quite a little foggy thing, okay, in urology. But you will see that is very, very important to talk about prevention also in urology, and also awareness. Is not a lesson. So every question that you have, you can do whatever you want. Okay. So this is the agenda for today. We will talk about primary prevention. So first of all, a tumor that benefits from risk factor reduction, then something that benefits from vaccines, and then secondary prevention with a very important tumor that deals with urology, and we will finish with health promotion and awareness, talking about awareness. Okay, primary prevention, we start with urothelial cancer and risk factor reduction. Here you can see a very frightened bladder in the slide, because urothelial cancer, as you know, is more frequent in the bladder than in the upper urinary tract. So we are talking not exclusively, but of bladder cancer. Here you can see white paper of, okay, because of the, okay, can you hear me? Yeah. Here you can see white paper published by European Association of Urology, that is our leader association in Europe and worldwide, because it has the same importance as the American Urology Association. What are white papers? Are policy recommendations for better support some kind of patients with urological pathologies or other pathologies, okay? White papers are not only in urology. In this case, this paper was published on bladder cancer. Why is so important the impact of bladder cancer? First of all, is the fifth neoplasm that can grow in a person, and is the 6% of cancer incidence in Europe. But the most important thing in this case is that is a very costly pathology. Look at the values of these numbers and think that is even more important in Southern Europe because it's the area worldwide where, in Europe, not worldwide, where we have the major incidence of this pathology. And as you well know, we have different risk factors for bladder cancer, for urothelial cancer. The most important ones for our speech are smoking and exposure to chemicals. They're important because, here you have two slides that I prepared from the white paper of EAU, because the European legislation try to improve with policy recommendations the prevention of these two risk factors. First of all, European Union try to improve legislation in the field of occupational cancer with agency that is the European Agency for Safety and Health at Work that focuses in two main things that are the monitoring of the exposure to relevant chemicals. As you may know, we are talking about dye, about rubbish factories, chemical factories, etc. And most important, so first of all, an action of monitoring the relevant chemicals, and second, to create and improve, if they're existing, database of cancer-causing chemicals. In every time, as urologists, we do first diagnosis of a bladder cancer or urothelial cancer. We have always to ask the patient if there is a risk about occupational chemicals, etc. So we have to ask actively the patient if there is something in his or her history, professional history, that deals with these risk factors. That's why it's so important, and European Union wants to improve this kind of monitoring. And the second one is to improve legislation in the field of tobacco control. Look at the first sentence. The EU Beating Cancer Plan goal to create a tobacco-free generation by 2040. I don't know if is realistic or not, but this is the main aim of the EU policy recommendation. First of all, always monitoring the situation. So, address the differential rates of smoking between the member states of EU. Just to have some data, we range from 28% in Bulgaria, we have some Bulgarian here, no? To 6% in Sweden. So the range is that in European Union. The second point is to use taxation instruments and to have the same taxation between the different members of the European Union, to create smoke-free environments and to extend the smoke-free environment, for example, the university or the hospital, also in the external environment, and to cover this type of control also to new products, so e-cigarettes and health and heat products of tobacco. And last, the revision of two directives, both on the, for example, packaging of the cigarettes with the images of a lot of things that can happen with smoking, etc. And also advertising, so to control the advertising, the banner, also for e-cigarettes and new products related to tobacco. Why is so important also for other products than tobacco? Because we have, for example, this study that is published in 2021, so it's not so actual. And we have, in 2021, we already know that with e-cigarettes, we have biomarkers of carcinogens, several with a strong link to bladder cancer. We don't know if they act as for bladder cancer because we don't have a lot of follow-up for these patients. But we have to study if there will have implications of urothelial exposure to these toxicants. So that's why it's so important to enlarge the legislation also to other products than tobacco. So for bladder cancer, we have two risk factors requiring a strong and effective policy response that are occupational cancer and tobacco control. And we have to pay attention to e-cigarettes and heated tobacco products, as you can see from the last slide. And we move to another type of primary prevention. No, okay.
Some questions from the floor? Some, please.
I haven't understand well which is the relation between the tobacco and the urothelial cancer. I mean, the pathophysiological mechanism that leads to is related to the carcinogenic substances that are inside, and then if it is like that, why specifically to the urothelium and not other sites of the body?
Good question. Yeah, we have a problem with the metabolite of some products in cigarettes. For example, polycyclic amines, etc., that are present also in the case of the occupational cancer. And the problem is that why in the bladder? Because we have a concentration of these metabolites for a long time. For example, 3 to 4 hours, if we go to the toilet every 3 to 4 hours or more. If we go to toilet 2 times per day, we have a lot of carcinogenic metabolites that are inside the bladder for a long time. Okay. Yeah. One of them is that, and then the most important are the polycyclic amines. Mm-hmm. Okay, thank you. The second type of primary prevention in urology is, for example, the HPV, so the human papillomavirus. Why is so important? The WHO has prioritized the inclusion of the vaccine for HPV in national immunization programs all over the world. We have 3 preventive HPV vaccines. The latest one is the non-valent one, is obviously the more costly, but is also the more, it has more efficacy because it targets 9 different types of virus-like particles. The numbers are not so brilliant because in 2019, only 4% of men were fully vaccinated worldwide. So we have a lot of work to do. Here I present two studies. One of them is a systematic review of a lot of participants. You can see 13 studies included with 8 RCTs. What is the most important thing to know? That these vaccines are the efficacy of these vaccines is very good. Look at the numbers, for example, talking about urology. 90% of efficacy against genital condyloma, that are a risk factor for penile cancer, and also in women for cervical cancer, etc. So a very good efficacy. So these results support vaccination in young men. And what is the panorama, for example, in Italy for the HPV vaccination? These are data that has been recently published in this study, the Obvious project. Obviously, you have to vaccinate. That's why the name is that one. HPV vaccination has been offered actively and free of charge to 11-year-old girls in Italy since 2007-2008. 3 regions in 2015 started to do the same with males, with 11-year-old males, but the whole country reached a full offer to the vaccination to males in 2018, up from 11-year-old up to the age of 18. These are the numbers from Italian Ministry of Health. For males, 50% of males born in 2006 have received the HPV vaccine. Slightly more in women, 62%. The aim of WHO is 95%. So worldwide is 4%. In Italy is 50%. Another problem was the COVID pandemic, because of all the vaccinations other than COVID has declined in the past 2 years. And so it's very important, the information about this vaccine, about this pathology. That's why we have from this year this type of advertise that is hai prenotato vero, which means have you reserved right? HPV, hai prenotato vero, okay? That inform boys, girls, and parents, because they are 11-year-old boy and girls, what is the papillomavirus, why is so important to vaccinate against papillomavirus, and how to do it, okay? In the website of hai prenotato vero, we have all Italian regions with different types of phone numbers, emails, etc. to contact to actively vaccinate people. And the 4th of March was the HPV Awareness Day. So the Awareness Day on human papillomavirus. Look at the post with the hashtag HPV Awareness Day. And so it's important also for social media to inform people about vaccination on HPV. So just a brief take-home message, recommend vaccination. Okay? That's true for all the pathologies that we have, the disease that we have, and we have the vaccine also for HPV. Questions? In males, penile cancer in Italy is very rare, so is less than 2% of the cases. All over the world, in non-Western countries, the incidence is higher. For example, in Africa is a big problem in the health, African health. The bigger problem here in Italy and in Europe deals with the cervical cancer. So the male just as a vector of HPV from male to female. The cervical cancer is, the incidence is more than 2%. The first thing is that it's not so easy to see the cervix. For example, if you don't do gynecologist visits, etc., as is recommended, the penile cancer is more visible. That's why there is a difference in incidence in Western countries. Okay. Okay. So we move to the secondary prevention, so early detection, and we talk about prostate cancer. So very, very important cancer, not just in urology. Why? Because it's the second tumor for incidence in males. The first one is lung. The second one is prostate, but the numbers are very close. Fortunately, the mortality is not as for the lung cancer. We can see an incidence of 40%, 14%, and a mortality of about 7% for prostate cancer. These are the last data of 2020 of the Globocan, that are global cancer statistics. Here you have a map of the incidence and mortality. Look at the green. The green are the nations where the prostate cancer is the first in incidence. So we have the Americas, a large part of Africa, Australia, and Europe, the western and northern part of Europe. The EAU obviously published white papers also on prostate cancer with recommendation to European Union to do something against prostate cancer. And just in the first part of this paper, we talk about risk factors for prostate cancer. We have unmodifiable risk factors that are the aging of the population, the African ethnicity, and a family history of prostate cancer. But we have also other type of risk factors or protective factors, like the one that you see here. But the most important is that there is currently no high-level evidence that specific preventive measures may reduce the risk of prostate cancer. So we cannot talk about primary prevention in prostate cancer because we don't have scientific data supporting this. That's why we have to move to the early detection, okay? The early detection is based on PSA test. All of you knows what is a prostate-specific antigen test, I hope. And the landscape of the diagnosis of prostate cancer was revolutionized in the early 90s from this test because it enhanced the early detection of prostate cancer. What was the problem? That we diagnosed and treated a lot of prostate cancers that were indolent from the clinical point of view. So were tumors that we didn't have to diagnose. That's the definition of overdiagnosis. And to treat. So I can diagnose an indolent prostate cancer. I know that is an indolent prostate cancer. I don't have to treat it. But in the past, in the early 90s, we treated all the prostate cancers, the indolent, the clinically significant prostate cancers, etc. And the debate between an early detection of prostate cancer by using PSA or not to detect prostate cancer was based mainly on two randomized studies. One of them was a European one, and the other was an American one. The first RCT is called ERSPC, the European Randomized Study of Screening for Prostate Cancer. And the other one was the PLCO, and we will see in the next slide. The primary aim of the two trials was the same and was a reduction in cancer-specific mortality. The European study concluded that there was a significant reduction of 20% in prostate cancer-specific mortality in favor of PSA screening. That persisted after a long-term follow-up. The American study, the American trial, the PLCO, so the prostate, lung, colorectal, and ovarian trial, cancer screening trial, demonstrated the opposite. So there was not a substantial difference between the study group with the screening and the control group, the usual care. That's why in 2012, the US task force recommended against the PSA screening, and there was a big debate on the scientists that found PSA, that recommended against his test against PSA screening, etc. But re-evaluation in 2016 of the results of this test concluded that approximately half of the men in the control group received at least one PSA test during the study. So the results were completely different when we excluded all these patients in the control group that did an opportunistic screening by measuring on their own the PSA. And in conclusion, also in this test was shown a reduction in mortality. So the two RCTs finally concluded that PSA screening demonstrated a reduction in prostate cancer mortality. But we don't have any screening all over the world for PSA. Why? The first to think about the feasibility and effectiveness of an organized prostate cancer screening was the Council of the European Union in 2022 by selecting a project that was the Praise You project, Prostate Cancer Awareness and Initiative for Screening in the European Union, to evaluate the early detection and diagnosis of prostate cancer through screening programs, different screening programs. So, who knows this song? No one of you. No one knows Fatboy Slim. Okay, you win the the bet. The song is called Praise You, and every time I read Praise You, the name of the project, I remember Fatboy Slim, but we are too old. That's why. Okay, Praise You Consortium. The first thing that they did was just to see a picture of the screening in Europe, the PSA screening. This is the review of all the papers published on this subject in 9 European countries: Germany, France, the Netherlands, Croatia, Ireland, Czech Republic, Lithuania, Portugal, and Spain. And these were the results. Very interesting. What are the policies in European Union and the recommendation for PSA screening? In France and in Germany, recommendation against population testing. In the Netherlands, against the population and individual testing, so more strict than in France and in Germany. In Ireland, the PSA is included in the yearly routine checkup, so it's not a screening, but a sort of screening. In Lithuania, we have an unorganized population-wide testing, and in Spain and Italy, an opportunistic testing. What is opportunistic testing? Is the male that come to the GP or the urologist and ask for a PSA, or just pay to have a PSA testing. Here you can see that in all the European, all the countries that we talked about, we have a form of opportunistic screening in yellow. And there is a high level of opportunistic screening in all the countries of Europe. For example, in Italy, about 75% of men aged more than 50 had a PSA test in the last year. So we don't have a screening, but a very high opportunistic screening. And what is the request of this group, of the Praesio group? Just to reduce overdiagnosis and overtreatment with changes on a policy level. So it's important to have an early detection of prostate cancer. It's important not to have an overdiagnosis and overtreatment. So we have to change something on a policy level with multidisciplinary discussions, social media and social medical campaigns, with a so-called detection program that is not really a screening, but is a risk-based strategy based on age groups. The cutoff here is 60 years old. Then different PSA levels and different things like urology visit, digital examination, MRI. So the early detection, maybe, we don't know, but have to be based on a risk-based strategy and not screening. So the take-home message for prostate cancer is that, first of all, we don't have high-level evidence that specific preventive measures may reduce the risk of this cancer. We have to improve early detection, but with less overdiagnosis and less overtreatment. And we have, maybe in the future, to use more evidence-based, risk-adapted algorithms. Thank you. If you want to
some questions.
ask
This
something.
is probably the most important topic because prostate cancer is very common among the male population. So this is a very important point. Do you have any idea about the program policy in your countries? About the PSA? Please. Okay, so a sort of opportunistic screening. Okay, good. We do the same, as Professor Manfredi said. In Italy, we use an opportunistic screening. There is not a formal program, but more or less all males that comes at our outpatient visit has a request for PSA screen, for a PSA test. So we have we have a large amount of population that had this screening, this test. Okay. Okay. Anything else? Good. Few words about testis cancer. Yes. So testis cancer is somewhat important because not because it's very frequent in population, in male population, but because affects young patients. All the tumor that we have seen affects older population, but in this case we talk about guys. We talk about people between the 18 and 40 years old. Okay, so I think that this is the most important thing that you should remember when we talk about testis cancer. Here you can see the rate of incidence, 1% of adult neoplasm, so not too much, but there is, again, you should remember that the people are young, 3 to 10 new cases for 100,000 males per year. So there is a somewhat low number with respect to the numbers of prostate cancer, for example, or with respect to the number of bladder cancer. But again, you should remember that you deal with the life of a young patient. Okay? Few words about the epidemiology of this cancer. As you know, we know some risk factor for testicular cancer. I have to be honest, the most important is cryptorchidis. All the other risk factors probably are more theoretically than practical. So if you have to remember one thing, you should remember cryptorchidis, because the males with cryptorchidis in your life has 20 times the risk with respect to one people on the population, on the normal population, to have a testis cancer. So if you deal with a patient with cryptorchidis, you should remember this data, okay? All other risk factors has a very low impact in the development and in the diagnosis of prostate cancer. Sorry, the testis cancer, okay? Another very important thing is a contralateral testicular tumor. If patient had a cancer, had a testis cancer, had a chance to have the cancer in the other testicle, okay? And this chance reaches to 5 to 6% in the life of the patient. So you should remember that if the patient has a cancer, you should suggest controls also in the other testicle. Few words about pathological classification. As you know, testicular cancer can be divided into two groups. The first group is the seminoma. Is the more frequent, is the more has a favorable prognosis with respect to the other, which is a non-seminoma cancer. Inside this group, you may have different types of pathology. More or less, it's the same of the lymphoma. You have the lymphoma, the Hodgkin lymphoma or non-Hodgkin lymphoma. Here is some quite similar. You have seminoma and non-seminomas. Non-seminoma has a worse prognosis, but in general, as you can see in the next slide, in general, the rate of cure of this tumor is very high. You may have also a very, very small, less than 5% of cases, different types of pathological tissue, for example, for the non-germ neoplasm, or other various neoplasms, such as carcinoid or testicular lymphoma, very low. I saw in my experience 2 or 3 cases of this kind of tumor, so very rare. What about the diagnosis? Because if you remember the diagnosis of testicular cancer, you may face the topic of prevention. As you know, diagnosis of testicular cancer has 4 pillars. First one is the clinical presentation and testicular palpation. This is the first step of the diagnosis, and prevention is based on this first pillar of the diagnosis, okay? Then you have the scrotal ultrasound, serological markers, and a surgical intervention to have a diagnosis, a histological diagnosis of the cancer. So, again, if we talk about the prevention of testicular cancer, we have to talk about clinical presentation and testicular palpation. Usually, the testis cancer is painless. Patient has no pain at the level of the testicle. In general, it has a unilateral testicular mass of hard wood consistency. So if you can feel, if you touch the tumor of the testis, you feel a very hard consistency of a very small or not small part of the testis, okay? This is very important. If you see something of tender in the testicle, probably is not a cancer, maybe a cyst, maybe a varicocele, but it's not a cancer. Rarely, the testicle may be painful because there is an increasing volume, a quick increase in volume of the tumor due to a bleeding, an intratumoral bleeding. Again, if you will read this sentence in all the texts of urology. I saw 1 or 2 cases in my lab that has pain due to intratumoral bleeding. So it exists, but it's not so frequent. Of course, but this is not prevention, of course, you may have some symptoms due to metastasis. In case of lung metastasis, for example, patient may have problem with cough or with lung insufficiency. Okay, dyspnea, and may have also renal colic due to compression of the urethra that causes hydronephrosis and pain, of course. Here you can see a very quick image of ultrasonography. As you know, you can see very well the tumor. The sensitivity is close to 100%, so it's very high. You can see usually a hypoechogenic lesion, but you can have also other kind of texture. So you may have also a mixed echogenicity of a lesion with hyperechogenicity. But you see in every case a mass inside the testicular parenchyma. As you know, you may have also the markers, alpha fetoproteins, beta human chorionic gonadotropin, and LDH that you can use as a serum marker. The last step is to have a diagnosis with the pathology. So you have to perform an inguinal exploratory surgery. So you have to operate your patient, to remove the cancer, and to send to pathologists to understand if there is a cancer or not. Okay? So this is only a brief recap of the testis cancer. What you should remember is that the treatment is very effective. So when you to make a diagnosis of testicular cancer, you have a high rate of chance, high rate of cure. Treatment options such as surgery, radiation, chemotherapy, alone or in combination, have achieved more than 90% of cure of our patients. So this is a rate that we cannot observe for other tumors, so this is very important. And a thing that should be remembered is that the stage of cancer at the time of diagnosis is a crucial factor, okay? So if you do a early diagnosis, probably you may save the life of your patient, okay? In this case, prevention is very important. If we talk about the prevention of testis cancer, we have to talk about testicular self-examination. Okay? It's very easy. You have not to use something special. You have not to use ultrasound. You have not to use test. You have to use your hands and to palpate your testis. This is a very quick instruction for the palpation of the testis. You should check the health of your testis once a month. Usually we suggest to control it under the shower. We have to check one testicle one time. We have to roll the testicle between the fingers and palpate if there is something of strange. We have to fill up the spermatic cord, which is posterior to the testicle, and we have to feel some hard lumps, for example, smooth or rounded bumps. We have to control, we have to check change in size of the testis, or shape, or consistency. There is very important, as I told you before, the consistency of the tumor is hard. So if you feel something of strange in your testis, especially inconsistency of your testis, you should call your doctor, you call your GP, okay? Of course, you may feel also painful areas. Again, this is a rare condition in which a tumor may give pain to the patient, but can happen. So if you have pain at your testicles, it's better to call your doctors, okay? Here is the scheme for the palpation of the testis, between 18 to 40 years. Dimmi. Yeah. Yeah. It's very difficult to say. It's very, very difficult to say because you may have a very small lesion that stays stable during the time, and you can find a diagnosis, for example, by using an ultrasound you performed for other causes, for example, infertility, and you can see that there are stable masses during the time, months, for example. Sometimes the patient say, okay, the last month there is nothing, and now there is the mass. So it's very, very variable. There is no an answer to this question. Okay? Dimmi. So, testicular cancer is an incident, as I told you before, about 3 to 10 person for a year for 100,000, okay? Among this population, patient with metastasis of cancer is about 1/3. Okay? Okay, good. All kind of metastasis. As you know, the primary metastatic site is the retroperitoneum. So considering also the metastasis of the retroperitoneum. Okay, what about the screening? So I show you what you can check, the testicles, your testicles, but what about the screening and what about the awareness of the knowledge about the testicular cancer in general population? I found some paper that show us that the awareness of this problem is very low in general population, and is very low also in the university students. So all the events to improve these knowledges were more than welcome. So it's important to talk about this topic because, again, the awareness is very low all around the world, not only in Italy, but all around the world. But what about the effectiveness of the real program of screening? So in a program based on, for example, events like this, or lesson in the school of general program proposed by the Ministry of Health, for example. We have a paper published a couple of years ago in Denmark that suggested that the relative cancer mortality reduction with a formal screening of testis cancer is performed is around 30%. So very interesting numbers, about 30%. But if you take a look to the absolute cancer mortality, we save less than death life for 100,000 of men. This is an important number for the 10 people that you consider, but if you take a look in general, this is a very low number, because if you consider the same rate for the breast cancer screening program, you may save more than 1,000 lives if you apply this screening control. So in this case, the number of the life that you save with this screening is low with respect to other cancer. Why, in your opinion? Very simple. Because the incidence of this tumor is low, and the cure of this tumor is very good. So if you take together these points, you have the reason that justify this data. But if you take a look to the generally age of the patient, as I told you at the beginning of the speech, you should remember that you save many years to your patient, because you have 50 life years gained per death. So a very high number of years that you spare and that you give to your patient if you apply this kind of protocol, this kind of prevention program. Unfortunately, due to the low number of lives saved, again, less than 10 per 100,000 of male, the EAU guidelines on testicular cancer say that there are no high-level evidence studies supporting screening programs. So if you open the guidelines of EAU and you search for prevention screening, prevention of testicular cancer, you cannot find a screening program, okay? What is the population that you can involve in a screening program? This is the population with cryptorchidism. So you have to tell to your patient with cryptorchidism in his life that he should be used this kind of prevention. Okay. In Italy, we have a couple of programs, all based on international society, on national society, scientific society. For example, this is a program of Società Italiana di Urologia. And in this case, the Società Italiana di Urologia, Italian Society of Urology, suggests the use of this screening. But again, there is no a formal screening of the Ministry of Health, for example, okay? What is our conclusion? The testicular self-examination is simple, is cheap, does not require special equipments or medical instruments. It's very easy to do. Everything can do it. It may save life. And even if the data of the literature are not enough to recommend its use to the general population, we suggest the use of TSE in young male at least once in a month. Okay? Thank you. Question? Okay.
The last part of the speech, okay? And we talk about awareness, strictly awareness, with bladder performing yoga for urinary incontinence, okay? Another publication of European Association of Urology, a lot of publications. That one is called An Urge to Act, okay? So is a publication on the health, socio-economic and environmental costs of continence problems in the European Union. So you have also the environmental costs that is very actual now, okay? And another publication about EAU that is a manifesto for policy reform in continence health. Why is it so important to elevate the awareness on urinary incontinence? Because of the numbers. Here, very small, but you can have all the data. You have all the members of the enlarged European Union, because we have also, for example, Moldova, with the prevalences of urinary incontinence both in females and males. Look at the number, 22% of females in Europe have to deal with this problem, and 10.5% of males, okay? So huge numbers, but it's not just a question of number, it's also a question of economic burden. Here, another map of the Europe. We have different percentages of total GPD that in 2023 were used for from the members to treat and to follow up people with urinary incontinence, from 0.19 in Italy to 0.72 in Ukraine, okay, of the GPD. And in the other graph, we have the economic burden per patient. For example, in Luxembourg, we have more than 4,000 euros per year spent from a patient point of view for urinary incontinence. Okay, so it's a huge problem, both due to numbers and due to the economic burden. Not only for from an economic point of view, look at the value of economic burden is equivalent to half the direct medical cost of a diabetes, but no one speaks about costs of urinary incontinence, and at least 2/3 of the economic burden of cancer. So very huge numbers. And the problem is that urinary incontinence is sure to increase due to an aging population. In Europe, we have a lot of aging population and more aged people. And as I said before, is also a problem for the environment. Think about the production of pads, the recycle of pads that up to now is not possible to recycle, for example, pads, etc., diapeders. So it's very important to talk about urinary incontinence from a policy point of view, okay? And these are the 10 points of the manifesto that European Urology Association published to initially think about the problem. So first of all, have a European strategy, not just an Italian or Portuguese strategy, but a European strategy. Then give everyone an access to an equal access to continence health solution. Guarantee access to toileting facilities. So it's not just theoretically, it's also build facilities to in public and private spaces for people with problems of incontinence, for example. Improve the number of trained healthcare providers and support informal caregivers, for example, the sons of an old patient with urinary incontinence. Find and found sustainable continence care solution for health systems and also for the environment. Understand the interconnections of continence and related health domains, for example, obesity, for example, pregnancy. Improve funding for research. Run the campaigns that you see, for example, for HPV Awareness Day. And encourage public-private partnership to improve continence health. Why, in your opinion, there is no an awareness campaign for urinary incontinence? It's very simple. Just because it's embarrassing. So it's more embarrassing talk about urinary incontinence than talk about HPV, okay? Just for that. Okay, thank you very much. So the prevention is a question of time, as said by Depeche Mode. Any one of you knows Depeche Mode? Yes, that's good. Pink Floyd? Rolling Stones? Imagine Dragons? I don't know, but the title was with time, so thank you.
Any question? Please.
Varicocele has a high incidence. What's the relation between varicocele, a male who comes a lot of times with varicocele, and testis cancer?
There is no relationship between varicocele and testis cancer. This is a good luck for us because varicocele is very, very frequent in young male, and on the contrary, cancer is not so frequent. But there is no relationship between the two different diseases.
Okay, thank you.
Thank you so much.
You can. I would like to thank the professors for coming to talk to us. And if you could please scan the QR code to leave some feedback for the lecture.
This is not exactly related to the cancer oncology topic, but it's related to urology. And is if the professors understand why there is like a global reduction in the fertility rates among males. Why does it seem that the fertility is diminishing? Yes.
It's a very interesting question, but I think that there is no one question because probably the fertility is diminished due to different causes. First of all, when you search a son, you are older with respect to the 80s, to the 60s or 50s, for example. Now, today, the age in which a male thinks to become father is 30, 35. When my father became father when he was 25, 22. Okay, so this is the first reason. Today we search for a son when we are older with respect to the past. Second, probably you have many different problems in the environment. So there are some particles in the air, in all we can eat, we can breathe, that can reduce our fertility, because there is a direct relationship between the environment and the rate of fertility. But I think that more or less the most important thing is the age. You have a decrease in fertility when you are older. And so this is the key of the problem. If you think to become father today, probably your rate of fertility is very high with respect to when you will a 40 years old man. Okay?
Does someone else have a question? No? Okay. I again thank you to Professor Manfredi and Professor Fiori. Yes. If there is anyone here in the audience that is not a member of EMSA Turin, please scan this QR code to register. Obviously, not the members of EMSA Lisbon.